Hi, my name is Mike Forman. I'm a trauma surgeon here. I'm the token trauma surgeon for the presentation today. And they asked me to talk about the topic is, oh my, that's a really bad chest injury. And so unfortunately, we've sort of presaged my surprise. I think to define that is, yeah, that's probably, oh my, a really bad chest injury. I thought about using that for my Christmas card, goodwill toward men, but my wife nixed it for some reason. I'm not sure why. So why are we talking about chest trauma? I have no disclosures. It's important. It's a significant cause of morbidity and mortality in our country. Trauma in general, largest cause of death under age 45. 50% of those are going to involve the chest from one way or the other. It's a very common location where you will have non-compressible bleeding. In other words, I can't stick a hand on it, make it quit bleeding, so they continue to lose blood. Despite that, only 15% really require an operative intervention. But the nice thing about the chest is that there's so much in there that you can mess with, okay? In this one small area, you can have cardiac injury, vascular injury, pulmonary injury, aerophagic injury. I mean, there's a reason that they put the X mark over the middle of the chest. That's what it's for. So the types of injuries that we can see, we see inhalational injuries, usually from smoke, other noxious gases. Blast injury, not something we see a lot of, it's more common in the military. Penetrating injury, and then blunt. Penetrating injury, I'm not going to spend really much time on because, quite honestly, from a technical standpoint, that's easy. If there's a hole in it, you go fix the hole. If the patient hasn't died by the time you fix the hole, you win. So it's not terribly challenging. Blunt trauma, on the other hand, has a few more nuances. And so the thing I thought I would talk about is, in my career, what's really changed in how we manage blunt trauma. The three things that have really changed are pain management, chest wall fixation, and ECMO. So we'll talk about those three as we go through. So if you talk about blunt trauma, again, from an epidemiologic standpoint, it's about 10 to 15% of the admissions that we get have something to do with blunt chest trauma. It's about 25% of deaths involve blunt chest trauma. And about 2/3 of those have rib fracture. Now, how many people here have broken a rib? Okay. I will tell you, earlier in my career, people came in with rib fracture, said, here's an aspirin, take it off, throw a pair, it's a rib fracture. Then I broke 4. Then I said, how much narcotic would you like to have? Anatomically, I can't explain it, but a broken rib is connected to every piece of your body. You can't blink or yawn without having your ribs hurt, and they never quit hurting. But importantly, if you have a rib fracture, it's an indicator of energy absorption. Now, how old you are makes a difference. Okay? It's really hard to break a 20-year-old's ribs, all right? They're very resilient. An 80-year-old, a strong wind will break, all right? But it doesn't matter beyond that in some ways because they hurt just as much. It really doesn't matter. But it is an indicator of how much energy you have absorbed in that. It's telling, though, this particular study where they looked at drivers who were over the age of 60 who died, and they looked at and had chest injuries. And of 50% of those, the biggest injury that they had, if you rank the injuries, was rib fractures. So it is not an insignificant process when you have a bunch of broken ribs. Graphically, you can see it here. Here we have, you're looking at the difference in death per rib with, I'm sorry, I can't use 65 and elderly. Do you mind if we say mature? But as you can see, obviously, as you go up, a number of ribs, morbidity and mortality goes up in both age groups. But look at the difference between old and well, obviously, same reason you don't transplant, a 70-year-old or an 80-year-old that has equivalent lung disease that you would a 20. There's much more resilience, there's much more reserve, there's much more ability to get through this problem. If you look at those numbers there, effectively you double the problem every time you go up with another rib fracture if you compare the two age groups. But an increase of 19% and an pneumonia increase of 27% per rib in those patients. So that's a fairly telling number. And again, the problem is pain. Yes, you have pulmonary disruption. Yes, you have all of these other processes. But pain remains a central problem with these folks. The number of ribs, again, 8 ribs hurts a lot more than 2 ribs does. The bilaterality, you can at least sort of hold on to one side, but if both sides are hurting, it's more difficult to deal with that pain. And then again, remember, it's an absorption of energy that causes this. And so the pulmonary contusion that underlies that interferes with pulmonary further in gas exchange also is going to complicate this patient's ability to deal with their problem. So pain is bad, right? I will tell you that with my 4 ribs, it's a good thing we weren't measuring my incentive spirometry because it dropped down way low. I mean, it was real, got to tell you, because it hurts. Coughing, oh Lord, coughing was horrible. Sneezing will set you free. Do not go around pepper. It's not what you want to do with rib fracture. But all of these things end up causing pulmonary dysfunction, and your patients get sicker, 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 and depending upon what their reserve is, they may get sick to death. So we start losing our reserve, we get hypercapnic, we get hypoxic, and then what do we do about it? Well, historically, this is what we've done. We've gotten the patient up, we've kept them moving, we've tried to get them to go, push through this, let's go. We still do. Pulmonary toilet, still try and do that. We try and clear the secretion so that they can get effective gas exchange. And pain control. And pain control is, I think, where we've seen the biggest change. Here's a patient. So this is a 39-year-old, BMI is greater than 40. She's hypertensive, has fairly significant obstructive sleep apnea. She's diabetic and was in a car wreck. She has some rib fractures over on her left-hand side. She's got a clavicle fracture. And she ends up in our intensive care unit simply because you know what's coming, right? So by day 3, she's still got 10 out of 10 pain. She's miserable. Her incentive spirometry is 500 cc's. And her oxygen requirements are going up and up and up. So you can see what's happening, right? This is an intubation, do something. And she's going to be on the ventilator. Who knows how long. So what do we do about this? Well, historically, we've had opioids. We know with everything that's going on, opioids may not be the best choice, although I've got to tell you, they felt really good. But we've got some non-narcotic methods that we can utilize as well. We got topical agents. My residents apparently have stock in the company that makes lidoderm. They put lidoderm patches on everything. I will tell you that, take that patient, for example, you put lidoderm patch on her back. By the time that lidocaine actually gets to where the nerve that's hurting will be sometime in the next just not going to happen. So the topical agents, unless you are absolutely BMI 20, they might work, but otherwise you're just, you're wasting money on those. Then we've got blocks. We can do intercostal blocks. Intercostal blocks work. They take time, and you have to poke the patient multiple different times because the anesthetic doesn't last. You can do intrapleural blockade with injecting it directly through the chest tube. You can do paravertebral. But really, epidural has been the one that we talk as sort of that's the gold standard for the patient as severe rib injuries. And then, of course, stabilizing it so if the ribs are not moving, we'll talk about it. There's problems with epidurals. The biggest problem with an epidural is you need an anesthesiologist to do it. I don't know about y'all, but I don't keep one in my pocket. I wish I had a break glass and bring your anesthesiologist. We don't have one. So it's a matter of getting them there. We're opening up the epidural space. There's a risk of bleeding when you do that, and so oddly, they don't want us to have our patients on anticoagulants. Well, as you can imagine, this lady is a little bit of a risk for a DVT, and so chemoprophylaxis is something that we take really seriously. And they want us to stop it, put the catheter in, keep it at a very low level while the catheter is there, and then stop it again before they'll take the catheter out. That's great as long as the patient doesn't end up with a massive PE in the middle of that, which the epidural catheter really doesn't help. There's a possibility of sympathectomy. And interestingly, there's very few papers that show that epidural catheters in trauma actually work. Most of the studies that have been done have been in non-traumatic cases. So here's our current algorithm. And there's two things that have changed in our algorithm. The first, ketamine. Now you like very early on. I've been a ketamine fan decades, and it's finally caught on and become popular, and we actually have it. It's available. And actually, we have a protocol that allows us to actually put it on the floor also. And it's amazing. Often, it's not enough. Still have next regional catheter that we place at the bedside. Start a ropivacaine infusion that gives us a nice lock. Excellent luck with that. I'll share with you. Here's the catheter itself. You run that in. You actually place the reservoir for 3 days, and it's been very effective. Pros of using this is that you can use it over multiple fracture areas. You can actually use it bilaterally. You don't have to stop the DVT prophylaxis. And the biggest issue is that you don't need an anesthesiologist to do it. Cons, sure. It's again, we're infusing a local anesthetic at a relatively high dose. We have to be careful about that. There's at least a possibility of enough systemic absorption that you could end up with an overdose. You might end up with the catheter intrapleural, depending upon how the placement goes, or if you've got rib fractures and pleural disruption. But intrapleural local anesthetic is another methodology that you can utilize in the first place for pain relief. So that's not really the biggest issue. The big problem is that if it doesn't work. If it doesn't work, then you've got a couple of options. Number one, we can actually put a second catheter in to give us better coverage. And then if that fails, you've still got the epidural that you can fall back on. This has been one of the other things that we have found has been very sonography to actually make sure that we're putting the catheter in the right place. Instead of doing it blindly, we can use sonogram at bedside to place it so that we know right on top of the rib. And that's been very handy. So what did we do for this lady? Well, as you can imagine, we tried to make sure that she had enough narcotics. All right. Well, the problem was that when we gave her enough, she had respiratory depression and altered sensorium. So that wasn't going to work. Epidural. Well, we called our friendly neighborhood anesthesiologist. They wanted us to hold chemoprophylaxis. Again, as you can imagine, this lady's just a little bit of a setup for DVT. We weren't real happy with that. They were not necessarily going to be available, and when they did look at her, they had some concerns about positioning. Okay. So what did we do? We put in the regional catheter and a sonogram. 2 hours after we placed it, her pain was now at a 3/10. Her incentive spirometry had doubled, and she was on room air. Because she was now pain-free, she could take deep breath, she could cough and clear her secretions, and she actually was discharged 6 days later, keeping the on-Q pump until the day prior to her discharge, and did well. All right, so this is my segue again. So let's talk about flail chest. All right, as you can see here, this gentleman, they have flail chest is just a bunch of rib fractures that all happen to occur together. There's a lot of romantic notion about what a flail chest is, what it does. But the definition is that if you've got 3 or more ribs adjacent or fractured in 2 or more places, then you have a flail segment. That means is that I have a piece of my chest wall that is now no longer connected to the rest of my chest wall. You have paradoxical motion, right? Because you have negative pressure on the inside as the chest wall moves out, this moves in, and vice versa. It was really thought of as a mechanical problem for many, many years. The physiology was thought that you have this thing, Pendelluft. In other words, because of this instability that the bad air basically was just going from one lung to the other because you couldn't really get rid of it. That's not really what happens. What happens is that you got a bunch of rib. Works like crazy every time to move. every time you breathe, they move. Both fractures, all ribs, each one of them moves. That hurts like crazy. You don't want to breathe. It also takes a fair amount of blow to actually collapse that in and have that rip. So the likelihood you've got an underlying pulmonary contusion to start with is also relatively high. But the original idea is that let's stabilize the chest wall. This is one of the early attempts. He doesn't. Just saying. Effectively, they've got a towel clamp went around. Now this is it worked. It didn't work because it stabilized his chest wall and now not have pendulift. It worked because now the ribs were moving less. So anybody who's ever had a fracture will tell you that the fracture hurts. Fracture moving is really. So if you can make the fractures not move by stabilizing this way, somebody came up with the idea of you could actually take a suction around that, put it on the chest wall. I can only imagine this guy got, put this on the chest wall and again suspend the chest wall out as a methodology to try and stop this. But again, what was happening is I'm now stabilizing the chest wall. So there were a lot of efforts until reasonable mechanical ventilation came around. And then they saw, well, I could take this same patient, this guy, I could put him on mechanical ventilation, relatively high PEEP, and effectively internally stent his chest wall, and that would make it all better. And when I first went into my training, that was the answer. What do you do with a big flail chest? You intubate them, you consider early tracheostomy, put them on high PEEP, and you wait and let the chest wall stabilize that way. So as a result, there wasn't a lot of interest in mechanical stabilization. Back in the 80s, some people got the idea that maybe we should look into that. This is just a number of articles related to mechanical chest wall stabilization that are on PubMed starting from 2006 up to 2016. There's been this explosion of interest because they came up with some devices that actually work. And now we can go in and we can physically stabilize the rib fractures and offer these patients pain relief. Here's that same patient. As you can see, they've got fairly high deformity on the chest wall. It's better to look at it on this with a 3D image. And so this is 3 different rotations of a 3-dimensional subtraction. See all these fractions. Just so you can imagine that he was in pain and he was having some mechanical issues with this as well. So we fixed him. So in the operating room. Really only 3 fragments back up in suspension with less mobile chest wall and a more functional piece. So indications, these are sort of general indications, 5 or more segments that are flailed. Symptomatic non-union, you will never have a happier patient, the guy who has a non-union of a rib fracture that comes in and has you fix it. They will send you Christmas cards forever because they love you. If you're doing a thoracotomy already and the ribs are badly displaced, it's a good time to do it. If you've got 3 or more severely displaced fractures that are symptomatic, if you've got respiratory compromise that goes along with it, and again, older patients are going to tolerate trauma and degree of injury less than the younger patients, and so we're a little bit more aggressive on those older patients. Sometimes it's a little bit different. This is a young guy, off the Capitol. Really impressive chest X-ray. Agreed? He was breathing fine, but he had gotten a CT scan anyway, and he did have 3 rib fractures. The first rib fracture, inhaling lung. Second one, spleen. So we took him to the operating room since he wanted to go back to work, and we thought that's probably not a good way to go back to work and do construction. We plated him, and as you can see, the 3 plates there, pulled him out, and he was able to go back to work and was a happy camper. This is a gentleman that was in a motorcycle, or was on a motorcycle, didn't stay on the motorcycle, failed that test, who came in and was complaining of a lot of chest pain. And as you can see, his chest x-ray is not terribly exciting. He's got a couple little fractures this side. We did something that's fairly unusual. We did a physical examination on the patient. And we did notice that he looked a little unusual there. He had a bit of a asymmetry on his chest, as you can see. We didn't know if he'd had a pectoral implant that had just moved over from the other side and he had doubled it. But on CT scan, as you can see, he had managed to kick out on the other. There he is intraoperatively. That's cartilage sticking up there, waving and saying hello. We were able to put him back together, and again, he did well. He was a very happy person when he woke up post-operatively. It is amazing how much less a big cut hurts than your rib sticking up through your pectoral muscle hurts. This is much less painful than what that was. And so he was a very happy person as well. All right, so we'll move on to the third thing that I wanted to talk about. What do we do with the bad one? Okay. Motorcycle collision, multiple fractures, open extremity fractures on all 4 limbs. As you can see, he's got a bit of a clavicle fracture there. He's got some problems with that left lung. As you can see on the CT scan, he's got some significant consolidation. We were not able to keep up with the oxygenation very early on, and he was requiring, I think he went through 40 units of blood in the first 24 hours, and his pulmonary status was deteriorating. This gentleman had a behavioral issue, and as a result of his behavioral injury, he just got run flat over by a car. Literally tire treads off the middle of it. Probably justifiable. As you can tell, he was having some ventilatory issues. His shunt fraction was huge. Everything that we did just continued to deteriorate. We could not oxygenate, could not ventilate him. You can see this gentleman fell off the scaffolding, had multiple contusions, had multiple pelvic fractures, ended up getting a huge amount of blood. As you can see, he's got some subtle changes on his chest x-ray. You could oxygenate him as long as you were continually bronchoscoping him. The problem is that every time you put the bronchoscope in, he went into a brady arrest. And so we were having some problems. So what do we do on those folks? Well, you may be able to see the ECMO catheter right there, but ECMO clearly was the answer. It was an absolute lifesaver. It has completely changed the way that we take care of severe pulmonary injury. The ECMO doesn't really treat the injury. What the ECMO does, it keeps the patient alive long enough to let the lung recover so that we can move on to the next step of recovery. Again, vena venous is what we use predominantly. Our series of trauma patients here thus far, we have 24 in the trauma registry, and we've got a 66% survival on those patients. The reason they live is because of people like this. This is a picture of part of our ECMO team. See Dr. Schwartz there in the middle. The reason they're smiling is twofold. Number one, they're in Phoenix having fun, and we're here working. But the second reason is that this is us receiving our Center of Excellence Award organization for ECMO. And it's because of the work that these folks did. that allows us to do our last patient. This is a 24-year-old who's riding his motorcycle in Oklahoma. You've probably seen on the interstate sometimes have this thing, caution motorcyclist cruise pavement. The reason is that you can get oscillation in the bike if you're not careful. Lost control of his bike, highway speed, went off. You may have also seen some places in the median where instead of having guardrails now, they've got the string cable, 5 feet, and about every so post. Well, he found a post and effectively impaled himself on the post. Taken to the trauma center in Oklahoma City. They worked on him for 3 days and were losing. And so they called us and he was sent down here. When he arrived here on 100% oxygen, his FiO2 was 39, and he was placed on ECMO. He had extraordinarily high metabolic demands. You can see his chest here. You'll notice extraordinary demands. He actually had a dual oxygenator that was put on board, trying to keep up with his demands. And he ended up with a 29-day stay on ECMO, survived, and was able to go home to his wife and children. Went back to Oklahoma for rehab and recovered. We did not fix his ribs, mainly because most of them were missing and he was too sick to have anything done. But it gives you some idea of the degree of trauma that this guy suffered. And clearly, if it were not for ECMO, this guy would have died. And so it's a service that we're very happy to be able to provide. So he ended up with a flap over here that was actually, it was just a simple rotational flap. He had gone long enough, everything kind of grainy. Yeah. So here's what we're dealing with, all right? Patient comes in, they've got multiple rib fractures, they've got pain, it restricts their ventilation, mechanical develop atelectasis, may have a contusion to start with, decreased vital capacity, they start retaining CO2, they get PQ abnormalities, they have secretion clearance issues, they have hypoxia, decreased FRC, and what ends up happening at the end of all that is you fall off the cliff, like Wiley. So what do we do in that situation? Our job is to come in and stop it here if we can. If you can stop it here, then don't have all of this development to keep Wiley from getting shoved off the cliff. In the event that we can't do that, then we've got a safety net. And those are the things that have really changed for me in my practice, taking care of significant trauma. So I hope I haven't given you conflicting information like this. It exists, I know. But thank you very much.